Our next lesson for today is about common urologic conditions. So here is a man and a woman. These are the common urologic conditions that are encountered by both sexes. The first would be urinary incontinence and voiding dysfunction. Urinary incontinence is defined as the involuntary loss of urine. This is more common in women than in men for a variety of reasons, including anatomic differences such as a shorter urethra and risk factors such as childbirth. Many patients may also suffer from bothersome symptoms without leakage of urine, such as overactive bladder, with symptoms having frequency and urgency of urination and often nocturia or urination at night, or obstructive symptoms such as hesitancy, weak stream, and incomplete bladder emptying. These conditions can have negative impact on quality of life, but they are also associated with serious health issues, including depression, anxiety, social isolation, and even falls and fractures in the elderly. So here are the three types of incontinence. The stress incontinence, which is the most common, causing involuntary bladder leakage. Urge incontinence, it results in the uncontrollable need to use the bathroom, and overflow incontinence, which appears as frequent constant dripping from the urethra. So this is the definition of those pictures that was shown earlier. As you can see, urinary incontinence can be divided into several categories, although patients, particularly women, may suffer from more than one type. Urge incontinence is involuntary loss of urine associated with urge to void. Stress leakage occurs with an increased intra-abdominal pressure, such as coughing or sneezing, and may relate to loss of sphincteric function, urethral hypermobility from pelvic floor laxity, often related to parity, or following prostatic surgery in men. Overflow incontinence occurs in the setting of obstruction, with urine leakage occurring with movement, causing overflow urine from a distended urinary bladder. The next one is the involuntary leaking, which can be caused by different types of fistula: vesicouterine fistula, vesicovaginal fistula, uretrovaginal fistula, and rectovaginal fistula. So these fistula are classified with the anatomic connection of different parts in the near the urinary tract, as you can see in this figure. So genitourinary fistulas typically result in the most severe form of incontinence with constant leakage of urine regardless of presence or absence of activity or movement. This can occur due to previous gynecologic surgery or rectourethral fistula in men from cancer, radiation, or previous surgical intervention.
Maayong adlaw sa inyo tanan. Karon adlaw magistorya ta tungkol sa overactive bladder o kaya sobra kaaktibo nga pantog. Ikaw ba ay babae na di mapugnan o mayat maya ay naiihi? Nagimata sa gabi na higit sa 3 ka beses para umihi? Naiihi ng 8 ka beses sa isa ka adlaw? Basin o ibi na yan. Kini ang agyanan sa ihi sa atong lawas. Una ay ang pantog na ipunan ng ihi. Ang normal nga gasulod ay 250 to 500 ml na ihi. Ug ang kidney dinigikan ang atong ihi. Naibalan nato sa overactive bladder. Sa wala, naa diri ang normal na pantog. Sa tuo naman, makita nato ang overactive bladder na sobra kaaktibo. Overactive bladder o sobra kaaktibo ng pantog, ito ay ang madalas na pangihi o daghan na ihi sa isa ka adlaw o lisod mapugnan ang pangihi. Sa mga pagtuon sa Estados Unidos, 33 ka milyon nga tawo ang adunay sobra nga kalihukan sa pantog. Kini gilang huban sa 40% nga mga babayi ug 30% nga mga lalaki. Kinsa ang mahimong OAB? Lalaki o babae, pareho lang sira. Nagdugang sa edad, walay gipili na edad ang OAB. Adunay problema sa prostata sa mga lalaki, mga babaeng mga nakaagi sa menopause, mga tawo na adunay problema sa nervous system. Mga sintomas sa usa ka sobra nga aktibo nga pantog or overactive bladder. Dili mapugnan ang pagtulo sa pag-ihi o urinary incontinence. Gibati kanunay ang pangihi o kaya urinary urgency. Regular na pag-ihi labi sa 8 ka beses sa usa ka adlaw or urinary frequency. Kanunay nga pangihi sa oras sa pagtulog sa gabi labi sa 3 ka beses o kaya nokturya. Mga sayop na pagsabot tungkol sa OAB. Isa, walay mahimo aron matambalan ang OAB. Ang tinuod, daghan mga butang na mahimo aron matambalan ang OAB. Matambalan gyud ang OAB. Ikaduha, na sayop nga pagsabot, ang pagbaton ng OAB mao ang abaga sa pagkatigulang. Ang tinuod, OAB dili normal bisan sa katigulangan. Ang OAB mahimong mahitabo sa bisan unsang kaedad. Mga rekomendasyon sa imong doktor. Ang imong doktor kung adunay ka-impeksyon sa ihi, may balhan, ang sakit sa nerbiyos, epekto sa mga tambal nga imong gikuha, gipadako nga prostate sa mga lalaki ug uban pang mga sakit sa pantog. So maghimo silang mga eksaminasyon, medical history, physical exam, ug sample sa ihi o dugo para mahibalan ang mga gisuspetsa na ay mga pagpaayo sa OAB. Una, pagbago sa batasan o behavior modification. Ikaduha, na ay mga tambal, pag-inom o mga tambal nga makontrol ang pampagawa sa ihi sa pantog, pananglitan, vesicare o metniga. Or pag-refer sa mga urologist o espesyalista para na ay pwede maoperahan o kaya kuryentehon ang mga ugat na magkontrol sa pantog nato. Pwede ta gamit sa voiding diary, adunay pwede ta mag-ehersisyo aron mapalig-on ang kaunuran sa pagkontrol sa ihi o Kegel exercises. Adunay regular nga oras sa pag-ihi o kaya pagsubay sa gidaghanon na pag-inom og tubig, paglikay sa kape, tsaa, iced tea, buko juice, na ay mga medikasyon sa OAB. Ang pananglitan ang solifenacin o vesicare o mirabegron metniga. Dili kinailangan nga agwantahon ang overactive bladder. Mangitang usa ka urologist nga duol kanimo para magpa-check up.
Treatments for urinary incontinence and voiding dysfunction are varied depending on the etiology, severity, and bother of the symptom. Urge leakage and overactive bladder can be treated by behavioral modification, time voiding, adjustment to fluid intake, timing of diuretic medication, and improved constipation. So bladder retraining, pelvic floor physical therapy, medications, anticholinergics and beta-3 agonists, or minimally invasive procedures such as sacral neuromodulation, percutaneous tibial nerve stimulation, or bladder chemodenervation with detrusor botulinum toxin injection. So this was mentioned also in the video previously done. Stress incontinence in women can be addressed by pelvic floor strengthening exercises. Vaginally placed removable support with a pessary, injection of urethral bulking agent, or sling procedures using propylene mesh or autologous tissue. In men, stress leakage is due to other iatrogenic causes or neurologic disease. Treatments include strengthening exercises, as in women, slings, or implantation of an artificial urinary sphincter. Overflow incontinence treatment is directed at the cause of obstruction, often benign prostatic enlargement in men with bladder drainage or Foley catheter insertion, medications such as alpha blockers or 5-alpha reductase inhibitors, or surgical removal of the obstructing gland or the prostate. When fistulas are present, adherence to surgical principles such as tension-free multi-layer closure, non-overlapping suture lines, and tissue interposition when possible offers the highest likelihood of success. Next common condition is, what's this? Erectile dysfunction. It is defined as the inability to achieve and maintain an erection adequate for sexual intercourse. So formerly this was known as a type of sexual dysfunction, but is now understood as erectile dysfunction. And it may be an early symptom of cardiovascular disease due to endothelial dysfunction. ED is a common disease for men later in life, with a prevalence rate believed to range anywhere from 30 to 50%, depending on age. Two large population-based studies showed that among men examined 40 to 79 years old, found that ED rates increased with age.
The body of the penis contains three cylindrical masses of tissue. The lower mass is the corpus spongiosum. The two top masses are the corpora cavernosa, which function as one entity and constitute the bulk of the penis. An elastic fibrous sheath called the tunica albuginea surrounds all three masses. A cross-section cut of each cylinder looks like a sponge because of the hollow lacunar spaces that fill with blood during an erection. As the erectile tissue relaxes, the lacunar spaces widen and become engorged with blood. As the tissue swells, it expands against the tunica albuginea, which presses against drainage venules, thus limiting blood flow out of the penis. As blood continues to flow into the penis, pressure increases, resulting in a rigid erection. An erection is essentially a vascular event that results from increased blood flow into the penis and reduced blood flow out of the penis.
Erections are triggered by a sexual stimulation, setting off a cascade of events. Nitric oxide is released from the nerve fibers and activating guanylyl cyclase, leading to an increase in cyclic guanosine monophosphate, or CGMP. The CGMP pathways leads to smooth muscle relaxation within the corpora cavernosa, allowing blood to fill the lacunar spaces. Once the lacunar spaces are full, the expanded tissue compresses the subtunical venules, thereby trapping blood within the penis and blocking venous outflow. So phosphodiesterase type 5 hydrolyzes cyclic GMP to reverse the process. There are multiple mechanisms leading to erectile dysfunction, including vasculogenic, neurogenic, iatrogenic, and psychogenic, but often it is multifactorial. Vasculogenic erectile dysfunction can be a result of cardiovascular disease, and endothelial dysfunction leading to cavernosal artery insufficiency. Diseases such as hypertension, diabetes, dyslipidemia, and tobacco abuse may increase the risk for erectile dysfunction. Nerve injuries due to diseases such as diabetes, Parkinson's disease, multiple sclerosis, spinal cord injury, or surgery, radical prostatectomy, abdominal perineal resection, and other radical pelvic procedures can lead to interruptions in the nerve signaling that causes nitric oxide release and therefore lead to erectile dysfunction. Iatrogenic causes may be a result of surgery, as described earlier, or medication use, as in some antihypertensives, opiates, anti-androgens, and psychotherapeutics. Psychogenic erectile dysfunction is a common reaction to stress and anxiety, and it is a result of noradrenaline release causing smooth muscle contraction and thereby inhibiting erections. These are the causes of erectile dysfunction. As mentioned, medications, previous surgeries, smoking, comorbids like diabetes, heart disease, and lifestyle, which is drinking. It could also be caused by stress and poor relationship. Treatment for erectile dysfunction begins with lifestyle modification by identifying any reversible risk factors such as stress, anxiety, medications, unhealthy diets, lack of exercise, and tobacco abuse. Medical therapy then begins with the use of phosphodiesterase type 5 inhibitors or PDE5. These work by prolonging the activity of cyclic GMP, leading to a continued smooth muscle relaxation, allowing more blood inflow into the penis. Common drugs include sildenafil, tadalafil, vardenafil, avanafil. The only available here is sildenafil and tadalafil. They differ in time to peak concentration, half-life, and the impact of lipids in foods. That's why sildenafil must be taken with an empty stomach. So here is the mechanism. It starts with a non-erect penis, and with stimulation, nitric oxide is released, triggering the cyclic guanylyl pathway, decreasing the calcium, smooth muscle relaxation, then the formation of erection, which traps the blood in the cavernosa. Common side effects include headache, heartburn, facial flushing, nasal congestion, and myalgias. Patients on nitrate-containing medication should not be given PDE5 inhibitors due to the risk of having severe hypotension. Vision-related conditions like macular degeneration, retinitis pigmentosa, and non-arteritic anterior ischemic optic neuropathy are cause for increased awareness and possible ophthalmologic consult. So here are the safety precautions for the medication. Keep it away from the children. Only men with ED should take it. Avoid taking alcohol or smoking. Avoid overdose. Avoid nitrate-containing drugs. And avoid grapefruit products because it affects the pharmacokinetics of the PDE5 inhibitors. Second-line options for treatment for ED include vacuum erection devices, intracavernosal injections, and intraurethral suppositories. Vacuum erection devices is a mechanical device composed of a cylinder placed around the penis, which then uses a vacuum to create a negative pressure and pull blood into the penis. In order for blood to stay in the penis after the vacuum is released, a tight constriction band must be placed at the base of the penis. There is a poor compliance due to difficulty with use, and a common reaction is petechiae, temporary paresthesia, color changes, and the penis being cold to touch. So here is an image of vacuum devices. So you insert the vacuum inside, then make it enlarge by suctioning it till it enlarges. Then after that, you put a constriction band. It's just like choking the penis to let the blood stay inside the erected penis. So same as for these other examples. So next alternative is to do an intracavernosal injection. It uses a vasoactive substance, prostaglandin E1, alprostadil, for example, alprostadil, papaverine, and pentolamine, either alone or in combination to trigger the erection cascade. So patients are trained to give themselves a self-injection when they want an erection, and it takes approximately 5 to 15 minutes to have a full rigidity if they respond. With intracavernosal injection, there is greater concern for prolonged erection or priapism. So dose titration must be closely monitored. Intraurethral suppositories are composed of alprostadil in the form of a pellet, which is then placed into the urethra and massaged for absorption. With suppository use, there are concerns about efficacy, with only about 46 to 65% and compliance due to a burning sensation that limits the interest of some users. So here is what you do: about 90 degrees from the penis, you inject it in the corpora cavernosa, or either that or you put it inside the urethra. The third line treatment of ED is surgery placement of a penile prosthesis. So there are three main types: the malleable, the two-piece, and the three-piece. The malleable device does not inflate, deflate, and merely bends in and out of the position for intercourse. The two-piece and three-piece devices are inflatable and differ on the presence of separate fluid reservoir. So the two-piece device has a fluid maintained in the lower half of the penile cylinders, whereas the three-piece device has a fluid reservoir placed in the pelvis or abdominal wall. So overall, the inflatable prosthesis has a high patient and partner satisfaction rates with over 92% and 91% respectively. So here are some figures regarding the penile implants. So these are the two cylinders placed with the pump either placed in the scrotum or in the abdomen. Here, the pump is in the scrotum, the reservoir for the water is in the abdomen. Same as this one, and these are other figures. So this is how you do it. You place it inside, you implant it in the cavernosa, and once you want to have sex, you just press the button, and then the reservoir will fill the cylinders with saline, and then it will close, and then you're ready for action. Thank you.